Welcome back to the deep dive. Today, we're tackling something incredibly important, taking surgical source texts, the real deal from clinics and ORs, and breaking down the complete diagnostic path for breast cancer. And this really is high-stakes stuff. I mean, the numbers alone, you can't ignore them. About half of American women, 50%, will see a surgeon about breast disease sometime in their life. And the lifetime risk of actually getting breast cancer, it's sitting around 1 in 8 right now. So the process we're discussing, it really affects millions.
It absolutely does. And because those stakes are so incredibly high, accuracy is just,
Yeah.
well, it's everything.
Yeah.
Our sources really hammer this home. Misdiagnosis. That's the single biggest reason for malpractice claims in this area.
Wow.
Yeah. And it's particularly tough, unfortunately, for younger women, say 45 or under. Their breast tissue tends to be much denser, which can make the standard physical exam and even the traditional mammograms, frankly, misleading sometimes.
So you can't just rely on one test result?
Exactly. You can't. The whole process has got to be systematic. It needs multiple approaches, different kinds of tools, and you have to be relentless, really, in chasing down certainty.
Okay, so let's trace that journey from the very beginning, before any scans are even ordered. What usually brings a patient in? What kicks off this whole complex investigation?
Well, surprisingly often, it's actually the patient finding something themselves. Discovering a lump, that's still the most common way this starts, maybe around 30% of the time.
Just finding a lump.
Yeah. But clinicians, they need to be tuned into a much wider range of signs because, not all breast cancer shows up as a neat little lump. Other things that should trigger a full workup could be noticeable breast enlargement, or maybe one breast looking quite different from the other, asymmetry. Then there are nipple changes if the nipple suddenly pulls inward, what we call retraction, or if there's unexpected discharge, especially if it just happens spontaneously. Maybe it's bloody, or it seems to be coming from just one specific duct, or, any visible skin changes, like an ulcer that won't heal, or just persistent redness, erythema. Sometimes the very first clue isn't even in the breast itself. It might be an unexplained lump in the armpit, an axillary mass, or, much less commonly, some kind of persistent ache in the shoulder or chest wall that just doesn't make sense otherwise.
It really sounds like almost any deviation needs a serious look. But let's tackle the big one, the one that causes so much anxiety. Breast pain. People hear pain, they immediately think cancer.
That's a really, really critical point to clarify, and often it's the first bit of potential reassurance we can offer. Breast pain, clinically we call it mastalgia, is overwhelmingly linked to benign conditions, not cancer.
That's good to hear.
It is. Of course, it still needs investigating just to be sure nothing's missed, but mastalgia is usually more cyclical, maybe related to hormones, or just generalized soreness. It's not typically how cancer first presents. Cancer lumps are usually painless, actually, until they get quite large or start pressing on other things. So if pain is the main symptom, we investigate. But the worry level for malignancy is, thankfully, lower.
Understood. So the lump is there or some other suspicious sign, and we start the diagnostic journey. You said it's systematic. What are those key non-negotiable stages in the toolkit?
Right. The standard approach follows a really precise sequence. First, the bedrock, a meticulous physical examination. Then comes the advanced imaging, things like mammograms, ultrasound, which give us a kind of map and a working hypothesis. And finally, the absolute gold standard, the step that gives us the definitive answer, getting a tissue sample, the biopsy. That's what provides the actual pathology report. And critically, you have to correlate the findings from all three. Physical exam, imaging, biopsy. They all need to line up for us to be almost 100% certain before any surgery.
Okay, let's break down that physical exam. You said meticulous. It sounds like more than just a quick feel.
Oh, much more. It's highly structured. It starts with inspection, just looking carefully. And even that has a specific sequence.
Sequence for looking.
Yes. First, the patient is seated, arms just relaxed at their sides. We're looking for basic symmetry, size, shape differences. Then we ask them to raise their arms straight up, overhead. That can sometimes make subtle bulges or dimples pop out.
Okay. And then there's that classic pose, right? Hands on the hips.
Exactly. The third step is having the patient press their hands firmly down onto their hips. This contracts the pectoralis muscles underneath the breast tissue. We watch really closely during all three positions.
What's the logic behind those movements?
It's all about putting tension on the internal structures. If there's a cancer starting to invade the connective tissues, specifically those little Cooper's ligaments that support the breast, then contracting the muscle or stretching the skin by raising the arms can pull on that tumor. That pull causes visible tethering or dimpling or retraction of the skin or the nipple. It reveals fixation.
Got it. So the movements are designed to unmask hidden tethering. Beyond retraction, what other visual clues are you hunting for?
We're looking for any obvious asymmetry that might suggest a deeper mass is distorting the breast's overall shape. And crucially, we look for skin edema swelling. This often creates that classic peau d'orange look, literally skin of the orange.
Ah, I've heard of that.
Yeah, it looks like the peel of an orange, kind of pitted and dimpled. It happens when cancer blocks the tiny lymphatic drainage channels just under the skin. We also look for any persistent redness or skin breakdown, ulceration, which you might see with something like Paget's disease of the nipple. Oh, and one more technique our sources mention. Having the patient lean forward while they're sitting. Gravity pulling the breasts forward can sometimes accentuate a very subtle dimple or retraction that you might miss when they're upright. It's like one last check for those early signs of tissue involvement.
Okay, that covers the looking part. Now, palpation, actually feeling the tissue, technique must be absolutely critical here. How do you make sure you cover everything accurately?
Precision is key. The patient needs to be lying down, supine, flat on their back. This spreads the breast tissue evenly over the chest wall. Then the clinician systematically palpates the entire breast area, and you have to be strict about the boundaries.
What are the boundaries?
You go from the breastbone, the sternum, in the middle, all the way out to the big latissimus dorsi muscle on the side. And from the collarbone, the clavicle, up top, down to the top edge of the abdominal muscles, the upper rectus sheath. You cover that whole rectangle, often using a grid pattern or maybe a spiral pattern, ensuring no area is missed.
And how you actually feel the tissue matters too, right? You said avoid distortion.
Absolutely vital. You use the flat pads of your fingers, the palmar aspects. Gentle but firm pressure, pressing the tissue against the underlying ribs. The critical thing is not to pinch or grasp the tissue. Pinching creates folds and ridges that can feel like lumps when they aren't real pseudo-lumps. That just leads to false alarms and unnecessary anxiety. We're feeling for distinct masses or areas that feel different, firmer.
Makes sense. And palpation isn't just the breast tissue itself. Finding swollen lymph nodes, lymphadenopathy, is a huge part of this, right? Critical for staging.
Exactly. That's the second half of palpation. You have to systematically check the lymph node basins. The main area is the axilla, the armpit. We think about the nodes there in relation to the pectoralis minor muscle. Level I nodes are lateral, or outside that muscle. Level 2 are directly underneath it. And level 3 are medial, or towards the center, and higher up, sort of near the collarbone, the apical nodes. We also have to feel above the collarbone, in the supraclavicular area, and check along the sternum for parasternal nodes, though those are harder to feel. If we do feel anything a lump in the breast or an enlarged lymph node, it needs to be described meticulously. We record the exact location, the size, the shape, and really importantly, the consistency. Is it firm? Is it rock hard? And mobility. Does it move freely? Or does it feel stuck, fixed down? Fixation is a very worrying sign, suggesting that cancer might be invading nearby tissues. Often, drawing a careful diagram in the patient's chart is the best way to track these findings over time.
Okay, physical exam complete, suspicion potentially raised. Now we move to seeing inside, with imaging. Mammography is still the core workhorse, you said, whether screening or diagnosis.
That's right. Mammography has those two key roles. Screening is for women with no symptoms, usually just 2 standard pictures or views per breast. Diagnostic mammography is when we're investigating something specific, a lump found on exam, nipple discharge, focal pain, or maybe an unclear finding on a screening mammogram. We might take extra views or magnification views then.
Let's quickly touch on those standard views. Getting enough tissue in the picture is always a challenge, isn't it?
It is. The 2 standard views are the craniocaudal, or CC view, and the mediolateral oblique, or MLO view.
CC and MLO, what's the difference?
The CC view is taken top-down head to tail. It's particularly good for seeing the inner part of the breast, the medial side, closer to the sternum. And, crucially, the CC view allows for the best compression of the breast tissue.
Why is compression so important?
More compression spreads the tissue out thinner. This reduces overlapping structures that could hide a small cancer, it minimizes motion blur, and it actually allows us to use a lower radiation dose while still getting a sharp image. But the MLO view, that's arguably the single most valuable picture. It's taken at an angle, kind of side to side but slanted to run parallel with the chest muscle, the pectoralis major. That specific angle is designed to capture the largest possible volume of breast tissue in one shot. It reliably includes the upper outer quadrant of the breast, which is where a lot of cancers occur, and also that little tail of breast tissue that extends up towards the armpit, the axillary tail of Spence. Missing that area means potentially missing cancer.
Okay, so we have the images. If there is a suspicious finding, what are those classic red flags on the mammogram film that shout cancer?
Malignancy tends to have certain appearances. First, you look for a solid mass. But unlike a benign cyst or fibroadenoma, cancerous masses often have irregular, fuzzy, or poorly defined edges. The really classic sign is a stellate appearance.
Stellate, like a star.
Exactly.
Yeah.
It looks like the mass is sending out little spikes or tentacles into the surrounding tissue. We call that spiculation. That's highly suggestive of invasion. We also look for areas where the tissue just looks denser or thicker than the surrounding area in an asymmetric way.
And the other really critical finding, especially for early detection, isn't even a mass, right? It's microcalcifications.
Ah, yes, microcalcifications. Tiny little flecks of calcium, less than half a millimeter across. They are incredibly important. It's not just finding them, it's their pattern. Are they clustered together tightly? That's suspicious. Do they look different from each other in shape and density, what we call pleomorphic? Also suspicious. Or are they fine, linear, maybe even branching, suggesting they're forming inside the milk ducts? That's a huge red flag for ductal carcinoma in situ or DCIS.
Why are they so vital?
Because in up to half of cancers that you can't feel, these clustered microcalcifications are the only sign on the mammogram. Especially in younger women with dense breasts where a small mass could be completely hidden, finding these calcifications might be our only chance to catch the cancer at a very early, non-invasive stage.
Mammography is the workhorse, but then there's ultrasonography. You mentioned it helps clarify things. It doesn't replace mammography, though.
Correct. Ultrasound is usually used after mammography as a problem solver. Its main job is to look closely at something found on the mammogram, maybe a density or a possible mass, and figure out if it's fluid-filled, like a simple cyst, or if it's solid. That distinction is crucial because simple cysts are almost always benign, while solid masses need further investigation.
What do they look like differently on ultrasound?
A simple cyst is usually pretty obvious. It's typically round or oval, has very smooth, thin walls, and the inside is completely black, or anechoic, because the sound waves just pass right through the fluid without bouncing back. Benign, solid lumps, like fibroadenomas, often have smooth outlines too, and well-defined borders. Cancer on ultrasound, though, it often looks quite different. The walls tend to be irregular, jagged, maybe thick. The shape might be taller than it is wide. It might cast an acoustic shadow behind it, meaning the sound waves are blocked or scattered by the dense tumor tissue, making the area behind it look dark. Although sometimes cancer can be tricky. It might look relatively smooth, but show posterior acoustic enhancement where the tissue behind the mass looks brighter. That needs careful evaluation.
And ultrasound is also key for checking those lymph nodes in the armpit, right? Better than just feeling them.
Oh, much better. Ultrasound is significantly more sensitive for spotting suspicious lymph nodes. We look for a few things. Size is one generally. A node bigger than 10 millimeters raises concern. But more important is the node's internal structure. Its architecture. Yeah. A normal, healthy lymph node has a bright, fatty center called the hilum. That's where blood vessels go in and out. When cancer spreads to a node, it often replaces or destroys that fatty hilum. So loss of the fatty hilum is a very suspicious sign. We also look for thickening of the outer layer, the cortex. If the cortex looks abnormally thick and bulky, that's also concerning for malignancy.
Okay, 2 more specialized imaging tools. First, ductography. You said that's for nipple discharge?
Yes, ductography or galactography is specifically for investigating nipple discharge, but only certain kinds. We use it if the discharge is happening on its own, spontaneous, if it's bloody or blood-tinged, if it's coming from just one breast, unilateral, and especially if you can pinpoint it coming from a single duct opening on the nipple surface.
How does it work?
It's quite delicate. The clinician identifies the discharging duct, inserts a tiny blunt-tip needle or catheter just into the opening, and injects a small amount of X-ray contrast dye. Then mammograms are taken.
What does the contrast show?
It fills up that specific duct system, like plumbing. If there's a little growth inside the duct, like a benign intraductal papilloma, it shows up as a small filling defect, a spot where the contrast can't go. Cancer within the duct might look like a more irregular mass or maybe multiple little defects, indicating a more extensive process. It helps pinpoint exactly where the problem is for potential surgery.
And finally, the big one, magnetic resonance imaging, MRI. Sounds powerful, but you mentioned it's used selectively.
MRI is incredibly sensitive, meaning it's excellent at finding very small things. The downside is it's not always as specific. It can flag areas that look suspicious but turn out to be benign on biopsy, false positives. So we reserve it for situations where its high sensitivity really adds value.
Yeah.
Key uses include screening women at very high risk, for example, those with known BRCA gene mutations, or maybe younger women with extremely dense breasts, where mammograms are just really hard to read. It's also very useful for staging a newly diagnosed breast cancer. Studies show MRI can find an unsuspected second cancer in the other breast, the contralateral breast, in around 5 or 6% of women.
And within the breast that has the known cancer, how does MRI help the surgeon?
It's invaluable there, too. It helps determine the true extent of the known cancer. Is it just one spot, or are there other little areas nearby, multifocal disease, or even tumors in completely different parts of the same breast, multicentric disease? Finding extensive disease like that on MRI might change the surgical plan, perhaps shifting from just removing the lumpectomy, to recommending a mastectomy. So it's critical for planning the right operation. But there's a really important caveat with MRI's high sensitivity. If the MRI finds something suspicious that wasn't seen on the mammogram or ultrasound, you must investigate it further, usually with an MRI-guided biopsy. You can't just ignore it, but you also can't assume it's cancer without proof. And you need special equipment, like dedicated breast coils for the MRI machine, to get the best possible images.
Right, so imaging points the way, gives us a very strong suspicion, but it's not the final word. We need tissue. That brings us to biopsy techniques. What are the main options, like fine needle aspiration versus core needle biopsy?
Okay, so fine needle aspiration, FNA, uses a very thin needle, like one used for drawing blood. It sucks out individual cells, which the pathologist looks at under a microscope that's cytology. It's quick, relatively easy, often used for palpable lumps, especially maybe cysts you want to drain. But the big limitation is you only get loose cells, not intact tissue structure.
And why is tissue structure so important?
That's why core needle biopsy is really the preferred method for most suspicious solid lesions now. It uses a slightly larger needle, often spring-loaded, to take out a small cylinder or core of actual tissue. This core preserves the architecture, how the cells are arranged together. That lets the pathologist see if the cancer cells are still confined within the ducts or lobules, in situ disease, or if they've broken through the basement membrane and started to invade the surrounding tissue, invasive disease. That distinction is absolutely fundamental for treatment planning.
Makes sense. Now, what about those tricky lesions you can only see on imaging, like the microcalcifications? You can't just feel where to put the needle. How do you target those?
For non-palpable lesions, you absolutely need image guidance. If it's a solid mass visible on ultrasound, we use ultrasound guidance. The radiologist watches the needle on the ultrasound screen in real time as they advance it into the mass. But for things like microcalcifications or areas of distortion seen only on a mammogram, we need stereotactic guidance.
Stereotactic biopsy. Sounds complex. How does that work?
It is pretty high-tech. Yeah. Usually the patient lies face down on a special table with an opening for the breast. The breast is compressed, similar to a mammogram. Then the machine takes X-ray pictures from two slightly different angles. A computer analyzes these paired images and uses triangulation, like GPS, to calculate the precise three-dimensional coordinates X, Y, and Z of the target lesion within the breast.
Wow.
Yeah, it then guides the biopsy needle very precisely to those coordinates. For microcalcifications specifically, we often use a vacuum-assisted core biopsy device. This uses a larger needle and suction to pull more tissue into the needle opening with each pass, allowing us to get multiple larger samples through just one skin puncture. This increases the chance of successfully retrieving the tiny calcifications.
Okay, you got the core samples. How do you know for sure you actually hit the target? Especially with something as small as microcalcifications, you don't want to sample normal tissue right next to it.
That is a non-negotiable quality control step.
Yeah.
Specimen radiography. As soon as the tissue cores are removed, they must be X-rayed, right there in the room usually. We need to see the actual target, the suspicious calcifications, or the clip marking a mass inside a tissue sample on that X-ray.
So you X-ray the sample itself?
Yes. If you don't see the target calcifications in the specimen X-ray, the biopsy technically failed to sample the lesion, and you need to take more samples until you confirm capture. It prevents false negatives due to sampling error. And once we have confirmed we've successfully sampled the lesion, we place a tiny marker clip, usually made of titanium, right at the biopsy site through the same needle. This clip is incredibly important. It stays there permanently and shows up on future mammograms or MRIs, marking the exact spot that was biopsied. If the biopsy shows cancer and the patient needs surgery later, or maybe treatment before surgery, the surgeon knows exactly where the original cancer was located.
Okay, tissue obtained, target confirmed, clip placed. Now, the pathology report comes back, but you mentioned earlier this idea of concordance. What happens if the different pieces of information, the exam, the imaging, the pathology, don't seem to fit together?
Concordance is the final, crucial reality check. Everything has to make sense together. Let's say the mammogram shows a really nasty-looking mass, spiculated, irregular, highly suspicious for cancer. But the core biopsy report comes back saying benign fibrocystic changes only. That's discordant. The pathology doesn't match the high suspicion from the imaging.
So you can't just trust the benign biopsy in that case.
Absolutely not. When there's discordance, the risk that the core needle simply missed the cancerous part of the lesion or the sampling error is too high to ignore. You have to assume the imaging was right and the biopsy was wrong, or at least incomplete. In that discordant situation, further tissue sampling is almost always required. And usually, that means an excisional biopsy surgically removing the entire suspicious area. This is also how we handle non-palpable lesions that need removal after being marked with a biopsy clip. We use techniques like wire localization or radioactive seed localization, where the radiologist places a guide right before surgery so the surgeon can remove the whole lesion accurately. And again, in the operating room, the removed specimen is x-rayed to confirm the target lesion and the clip was successfully excised.
Right. Demanding that correlation makes total sense. Okay, so now the pathologist has definitive tissue and they're looking under the microscope. The first big split is non-invasive versus invasive, right? In situ versus invasive cancer.
Exactly. Carcinoma in situ means the cancer cells are still contained within the original duct or lobule where they started. They haven't broken through the basement membrane, that thin layer separating them from the surrounding breast tissue, the stroma. So by definition, they haven't invaded yet. There are two main types: ductal carcinoma in situ, DCIS, and lobular carcinoma in situ, LCIS.
And these two in situ types behave very differently, don't they, clinically?
Hugely different, yes. Understanding this is really key. DCIS involves abnormal cells growing inside the milk ducts. It can look different under the microscope, papillary, cribriform, solid patterns. The most aggressive type is called comedo-DCIS, which has high-grade cells and areas of necrosis or dead cells in the middle. The crucial thing about DCIS is that it's considered a direct anatomic precursor to invasive ductal cancer.
Meaning it can turn into invasive cancer if left alone.
Precisely. If DCIS isn't treated, usually by surgical removal, there's a significant risk that an invasive cancer will develop later, typically right there in the same spot in the same breast. So treatment is focused on getting rid of the DCIS locally.
Okay, DCIS is localized trouble waiting to happen. What about LCIS, lobular carcinoma in situ?
LCIS is quite different. It usually doesn't form a lump or show up on a mammogram. It's most often found incidentally, meaning by chance, when a biopsy is done for some other reason. It starts in the lobules, the milk-producing glands, and involves small uniform cells filling up those lobules. Unlike DCIS, LCIS is generally not thought of as a direct precursor that will itself turn invasive. Instead, finding LCIS is considered a marker of significantly increased risk, maybe 8 to 10 times the average risk of developing invasive cancer later on. And importantly, that risk applies to both breasts, not just the one where the LCIS was found.
Wow, so it's more like a warning flag for the whole system.
Exactly. It signals a higher susceptibility. Because the risk is bilateral and the LCIS itself is often widespread, multifocal, management usually focuses on risk reduction strategies, like taking medications such as tamoxifen, increased surveillance with mammograms and MRIs, or sometimes even preventative mastectomies, rather than just locally excising the area where the LCIS was found.
That's a really fascinating biological difference. Precursor versus risk marker. Okay, let's move to invasive breast carcinoma, where the cells have broken through that basement membrane.
Right. Once it's invasive, the cancer cells are in the surrounding breast stroma and have the potential to spread further. We classify invasive cancers based on their histology, their appearance under the microscope. The vast majority, maybe 80%, fall into the category of invasive ductal carcinoma of no special type, or NST. This used to be called infiltrating ductal carcinoma.
NST, no special type, so the default invasive cancer.
Pretty much. It's the most common kind. It typically shows up as a firm, hard lump, often in women, around or after menopause. When you feel it, it's often very hard because it tends to trigger a strong scarring reaction around it, what pathologists call productive fibrosis or desmoplasia. That dense scar tissue makes the lump feel firm and sometimes fixed in place.
Then there are the special types, making up the other 10–20%, with distinct features. Tell us about invasive lobular carcinoma, ILC.
Invasive lobular, yes. That accounts for maybe 10–15% of invasive cancers. Its hallmark under the microscope is how the cells grow. They tend to infiltrate the tissue in single file lines, like little soldiers marching. Pathologists often call it the Indian file pattern. These cells are often small and don't provoke that strong scarring reaction that NST does.
And that lack of scarring makes it harder to detect.
Exactly. Because there's no dense lump, ILC can be notoriously difficult to see clearly on a mammogram. It might just show up as subtle thickening or distortion of the breast architecture, easily missed. Clinically, ILC is also known for being frequently multifocal, multiple spots in one breast, multicentric spots in different quadrants, and more likely to be bilateral in both breasts compared to NST. One other key feature, over 90% of ILCs are hormone receptor positive, specifically estrogen receptor positive.
Okay, tricky to find. Are there special types that actually have a better prognosis?
Yes, thankfully there are. Tubular carcinoma is one. It's quite rare, maybe 1–2% of cases, often found on screening mammograms. It's characterized by well-formed, tube-like structures, and generally has an excellent long-term survival rate. It's almost always strongly hormone receptor positive as well. Another one is medullary carcinoma. It's interesting because it's sometimes linked to BRCA1 mutations, often looks quite large and fleshy, maybe even hemorrhagic. But paradoxically, it tends to have a better prognosis than the standard NST type.
And we should also mention Paget's disease of the nipple. That presents quite differently.
Yes, Paget's disease looks like a skin condition initially, like eczema or a persistent rash on the nipple and the surrounding areola, sometimes with crusting or ulceration. The definitive diagnosis comes from finding specific cells, large pale cells called Paget cells, within the skin layer, epidermis, of the nipple on biopsy. The critical point is that Paget's disease of the nipple is almost always a sign of an underlying cancer deeper in the breast, either DCIS or an invasive cancer. So finding Paget cells mandates a full investigation of the rest of the breast.
Okay, we've classified the type of cancer based on how it looks, but the modern diagnosis goes deeper into the molecular profile. Why are the receptors, estrogen, progesterone, and HER2, so absolutely fundamental now?
These three biomarkers, estrogen receptor, ER, progesterone receptor, PR, and the HER2 protein, sometimes called ER2, are absolutely crucial. They tell us about the biology of the tumor and, most importantly, predict how it might respond to specific treatments.
How so?
Well, many breast cancers, especially the well-differentiated ductal and lobular types, rely on hormones like estrogen to grow. If the cancer cells have estrogen receptors, ER positive, or progesterone receptors, PR positive, it means we can use endocrine therapy drugs like tamoxifen or aromatase inhibitors to block those hormone signals and starve the cancer. Over 70% of breast cancers are hormone receptor positive.
And HER2?
ER2 is a protein involved in cell growth. About 15–20% of breast cancers have too much of this protein or too many copies of the HER2 gene. We call this HER2 positive. These cancers tend to be more aggressive. But the fantastic news is we now have highly effective targeted therapies, like Herceptin, trastuzumab, and others, that specifically attack the HER2 protein. So knowing the HER2 status is vital for deciding if these powerful drugs are an option.
So positive receptors mean targeted therapies are possible. What about when they're negative, especially triple negative?
Right. If cancer is negative for ER, negative for PR, and negative for HER2, we call it triple negative breast cancer, TNBC. These account for about 10–15% of cases and are often associated with BRCA1 mutations. They have a distinct biology, they tend to grow faster, and have a higher risk of recurrence, especially in the first few years after diagnosis. And because they lack all three receptors, they don't respond to endocrine therapy or HER2 targeted drugs. So the main treatment backbone for triple-negative breast cancer relies on traditional cytotoxic chemotherapy. Identifying TNBC is critical because it signals a need for often more aggressive systemic treatment and has different prognostic implications.
That molecular profile really dictates so much of the path forward. Okay, let's shift gears slightly to recent advances. We talked about mammography, but the technology itself has improved dramatically, hasn't it? Digital breast tomosynthesis or 3D mammography, what problem did that solve?
The biggest limitation of standard 2D digital mammography was always overlapping tissue. Especially in women with dense breasts, normal glandular tissue can stack up in the compressed image, potentially hiding a small cancer or creating areas that look suspicious but aren't actually real, summation artifacts. Tomosynthesis, or 3D mammography, tackles this head-on. Instead of just one static image per view, the X-ray tube sweeps in a short arc over the breast, taking multiple low-dose pictures from different angles. A computer then reconstructs these images into a series of thin slices, typically about 1 millimeter thick. The radiologist can scroll through these slices, effectively looking through the breast layer by layer.
Like a CT scan of the breast, almost?
Sort of, yeah.
Yeah.
It dramatically reduces the problem of overlapping tissue. And the clinical data is really compelling. Major studies, like the STORM trial and others, have consistently shown that adding 3D tomosynthesis to standard 2D mammography finds significantly more invasive cancers.
Finds more cancers.
Yes, especially those small, subtle ones that might have been missed. And just as importantly, it reduces the number of women who get called back for extra pictures because of false alarms. By seeing the tissue in slices, radiologists can more confidently dismiss areas that are just normal overlapping tissue, sparing patients a lot of anxiety and unnecessary follow-up.
Is there more radiation with 3D?
The total dose for a combined 2D plus 3D exam is slightly higher than for 2D alone, but it's still well within the established safety limits. Most experts feel the benefits finding more cancers earlier and reducing false positives, especially in dense breasts, clearly outweigh the minimal increase in dose.
Okay, so 3D is a major step up in visualization. But what about patients who just can't have an MRI? Maybe they have a pacemaker or implants or severe claustrophobia. Is there another advanced imaging option? You mentioned contrast-enhanced digital mammography, CEDM.
Yes, CEDM is a really exciting and increasingly available technique. It's FDA approved. It works by giving the patient an intravenous injection of the same kind of iodine-based contrast agent used for CT scans. Cancerous tumors tend to build a lot of abnormal blood vessels to feed themselves. They're highly vascular, so they tend to light up brightly when they absorb this contrast agent.
How do you capture that?
Right after the contrast injection, special digital mammograms are taken. The machine takes pairs of images at different energy levels, and computer processing subtracts the normal tissue background, highlighting only the areas where the contrast is accumulated. Studies show its ability to detect cancers is remarkably similar to MRI, but it has big practical advantages. It's usually much cheaper than MRI. The exam is much quicker, maybe 10-15 minutes versus 45 minutes or more for MRI. And crucially, it can be done in patients who have contraindications to MRI. It combines the functional information about blood flow, like MRI, with the excellent spatial resolution of mammography.
Fascinating. Okay, let's pivot one more time. We found the cancer, we know its type and receptor status. Now we're moving into predicting its future behavior and tailoring treatment even more precisely with gene expression assays.
This is arguably one of the biggest paradigm shifts in breast cancer care over the last 15 years or so. These tests look at the activity levels of a panel of specific genes within the tumor tissue itself. They go beyond just size or grade or node status to give us a much deeper understanding of the individual tumor's biology and its likelihood of recurring.
What's the most common example? Oncotype DX.
Oncotype DX is probably the most widely used. It's a 21-gene assay typically used for patients with early-stage, hormone receptor-positive, HER2 negative breast cancer, particularly if the lymph nodes are negative. It analyzes the expression levels of these genes from the biopsy or surgical specimen.
And what does it tell the doctor and the patient?
It generates a recurrence score, a number between 0 and 100. This score predicts the risk of the cancer coming back somewhere else in the body, distant recurrence, within about 10 years if the patient is treated with endocrine therapy alone. But maybe even more importantly, it also predicts how likely the patient is to actually benefit from adding chemotherapy to their endocrine therapy.
And this has been proven in big trials.
Absolutely. The landmark Taylor's trial was definitive. It enrolled over 10,000 women. It showed that women with a low recurrence score, typically 0.25, depending on age and menopausal status, did just as well with endocrine therapy alone as those who also received chemotherapy. This meant thousands of women could safely avoid the toxicity and side effects of chemo. Conversely, women with high scores, above 25 or 30, clearly benefited from adding chemo. It truly personalized the chemotherapy decision.
Incredible. And there's another major assay, MammaPrint.
Yes. MammaPrint is another well-validated test. It looks at a different set of 70 genes and categorizes tumors as either low risk or high risk for distant metastasis. The key MUNDAC trial looked at patients who were considered high risk based on traditional clinical factors like tumor size and grade, but were found to be low risk by the MammaPrint genomic test.
What did MindAct find for those patients?
It found that those patients clinically high risk but genomically low risk actually did very well without chemotherapy. Their survival rates were excellent with just endocrine therapy. This again highlights the power of genomics. Identifying patients who, by older criteria, would definitely have gotten chemo, but whose tumor biology suggests they don't actually need it. It prevents overtreatment.
So these tools are really refining who needs aggressive therapy. Looking ahead, are we discovering even more genes that influence risk beyond the famous BRCA1 and BRCA2?
Oh, absolutely. The field of cancer genetics is constantly evolving. While BRCA1 and BRCA2 are still the most well-known high-risk genes, we now recognize several others. A key one highlighted in recent research is PALB2. It stands for partner and localizer of BRCA2. Mutations in PALB2 are now understood to confer a significantly high risk of breast cancer, potentially approaching the level of risk seen with BRCA2 mutations, maybe a 5 to 9 times higher risk than the general population. Finding a PALB2 mutation definitely impacts screening recommendations, often prompting earlier and more intensive screening, usually with annual MRI in addition to mammography, similar to BRCA carriers. It just underscores how our understanding of inherited risk is getting much more granular.
It's amazing how much information we can get now. Okay, let's try to pull all these threads together.
So, to synthesize this, diagnosing breast cancer is this really careful step-by-step process. It starts with that hands-on physical exam, moves to sophisticated imaging where 3D mammography, tomosynthesis is really improving clarity, but ultimately you need that core biopsy for the definitive tissue diagnosis.
But getting the tissue, as you said, is really just the starting point for the modern diagnosis, isn't it?
Exactly. The pathology report today isn't just a simple yes or no for cancer. It's a detailed characterization. Is it non-invasive DCIS, that localized precursor? Or is it LCIS, the bilateral risk marker? If it's invasive, is it the common NST type or the sneaky invasive lobular? And critically, what's the molecular signature? ER status, PR status, HER2 status? The whole goal has shifted from just detecting a mass to characterizing its fundamental biology so we can tailor the treatment precisely.
And that shift from just looking at size and nodes to understanding the molecular drivers with tools like Oncotype DX and MammaPrint seems like the most profound change. It directly impacts huge treatment decisions like chemotherapy.
It absolutely does. It lets us match the intensity of the treatment to the actual aggressiveness of the tumor's biology, not just how big it looks on a scan or whether it's reached a lymph node yet. It's truly personalized medicine in action.
So perhaps the final thought for you, our listener, to really chew on is this. With these incredible advances in imaging, like 3D mammography, and our growing ability to decode the tumor's molecular secrets and even inherited risk factors like PALB2, how is our very definition of early-stage breast cancer going to change in the next 5 or 10 years? And maybe more importantly, how ready are we as a healthcare system globally to actually integrate all this complex, personalized biomarker data effectively and equitably into routine screening for everyone? That challenge of implementation feels like the next big frontier.
It's a significant challenge, but definitely a worthwhile one if it leads to better, more personalized outcomes and helps patients avoid unnecessary toxic treatments.
Couldn't agree more. Thank you for joining us on this incredibly important deep dive today.